Hello and welcome to our weekly video following teaching this week in the Department of Medicine for the Elderly here at SASH. Today and this week you've been talking about delirium on your wards. Every morning we've had our little case study and our handover sheets, and we've been able to have a look at delirium and answer some questions, and hopefully they've got you thinking throughout the day.
It might be worth starting off with a definition of delirium. So, delirium is a disturbance of consciousness with reduced attention, changes in cognition, and perceptual disturbances.
So we're going to go through our 5 key points that we've covered this week. Each of your questions has related to one. So we're going to start with number 1.
So, point number 1 is that delirium is common. This drop in cognitive functioning, while people have a multitude of issues going on, is very, very prevalent in hospital inpatients. So, patients admitted to medical wards, for example, have an incidence of delirium of 20 to 30%, which is a lot of people. And the proportion of patients with delirium is even higher when you look at inpatients with fractured neck of femur. In their situation, the incidence can be as high as 30 to 65%. That's a huge proportion of patients. So when you're on the wards looking after patients, this is something you must keep in mind. In some patients, like people with fractured neck of femur, this could be half the patients you're dealing with or more. So lots and lots of patients could be struggling with delirium. And it's an important thing to keep in mind, because if you're not aware that they might have a delirium, you might just assume they're always confused, or perhaps this is an early dementia, when that may well not be the case. This could be a short-term delirium, and if you don't have that in mind, you might misdiagnose them. So it's important to remember that delirium is common. And one final thing on that point is that each year, delirium complicates hospital care for 2.3 million patients in the UK.
So our second point is that PinchMe is a great mnemonic for thinking of our causes of delirium, far bigger than just the classic we think of infection. So I think this is where we should bring in our case study, Barbara, who's an 87-year-old lady admitted to hospital following a fall at home and hitting her head. She also has a productive cough, and nursing staff report she has strong smelling urine. Over the course of her admission, she's been calm, chatty, able to have a good conversation with you. She lives at home independently, mobile around her home, and her son does her shopping locally. But today, when you go and see her on the ward, she's a bit more sleepy. She can't recall where she is. She can't remember why she's been in hospital. She's previously engaged really well with therapy teams, but today they're struggling to just get her out of bed. And on visiting her, you find that she's really difficult to keep awake, and she sort of falls asleep in a couple of minutes, and she reports she can hear birdsong. So our question was to think about was, what assessment should we do, and what are our clinical suspicions? So if we think about Barbara with our PinchMe mnemonic, we need to think about P stands for pain. Is she in any pain? Does she have any injuries? What are the results of her fall? Does she have any fractures or small wounds? Any other causes of pain that she might have? Abdominal pain, constipation, those sorts of things. Infection, this is I. So we need to look into that productive cough and the strong smelling urine. N is nutrition. How is her eating and drinking been prior to her admission? And also during her admission, is she eating her hospital food? We know hospital food is not patients' favourites, so how is she doing there? C is constipation. We cover that really well normally on the wards. When did she last move her bowels, and does she need any laxatives or any other interventions? H is for hydration. I think this is a really big one that we can all be better at as members of the MDT. Look at your patient's cup next to them. Have they got water in it? Have they got juice in it? Offer them a cup of water. Try and prompt them to just take a couple of sips. So we know our patients do not drink enough water. M stands for medications. Are there any medications that are causing her delirium? And E is for environment. So she's in a different environment. She's not in her home. She's not remembering where she is. So we need to have things to orientate her. I know in A&E, they've got the lovely dementia bays. They have got exactly where the patient is. It says you're at East Surrey Hospital. It's got the clock on the wall. And we need to just, every time we're talking to our patients, introduce ourselves and tell them where we are.
So the third thing that we want to talk to you about is how to assess for delirium. Now, with delirium being so common in the wards, this is something that we all need to keep an eye out for. And one way that we can do that is by using formal assessments that have been helpfully made for us. So the one that we want to teach you about today is called the 4AT. Now, let me tell you what that stands for. The 4A's are alertness, AMT4, which is something I'll get onto in a moment, attention, and acute change in cognition. So the 4AT as a whole enables rapid screening for cognitive impairment and delirium. This doesn't require any formal medical training, and anyone can do it. So whoever you are on the wards, whatever role you have, you can do this with patients who you think are slightly more confused than they would normally be. So let's break that down and go through each of the A's. So first up, alertness. If the patient is alert, they score no points. If they are less alert than normal or are drowsy, they score 4 points. Next A, AMT4. Now, this is a test that I'm sure lots of you will be familiar with. So it's broken down into 4 chunks: age, date of birth, place, and year, and is routinely something that a lot of us would do in the emergency department with new patients coming in. So if they have no errors in those 4 simple questions, they score 0 points. If there's 1 error, they score 1 point. And if there are 2 or more errors, they score 2 points. So you add those together, and we've got 2 more categories to go. Next is attention. So if they can tell you the months of the year backward and get 8 or more months correct, they score 0 points. If they get 1 to 7 months correct, they score 1 point. And if they are untestable and can't get any of the months of the year backwards, they score 2 points. And finally, acute change. Is this an acute change from how they normally are? If so, they score 4 points. If not, they score 0 points. Now, with each of those, when you add them together, you should have a score out of 12. If they score 4 or more out of 12 in the 4AT, it is suggestive of a delirium. However, important point just to mention at the end, if they score 0, this does not completely rule out delirium. So it's not a foolproof test, but can be a helpful way of picking up whether or not somebody has a delirium when they arrive with you.
Point number 4. NICE's primary management for managing delirium with our patients is using multi-component interventions. So these are things that every single one of the team can do. These are things like making sure patients have their teeth, introducing yourself, your role, who you are, where we are, ensuring catheter bags are nice and clean, keeping an eye on them, and trying to take out those catheters if they're not needed. Making sure we have clocks and on the wall and in visible places to orientate patients. Making sure family can visit. I totally understand that it's a bit difficult at the moment with all the rules, but try and facilitate those visits as much as possible. Making sure we're screening using tests like 4AT within 24 hours of admission. Making sure walking aids are nearby. And making sure that we have good, effective lighting to aid patients. Using these multi-component interventions decreases healthcare costs and increases quality of life years for our patients. And some research has shown it increases life expectancy. For patients who have a dementia and a delirium without intervention, their typical life expectancy is about 1.6 years following discharge. But for those with intervention who have dementia and delirium, it's 3.4 years. And for those with just the delirium, it's 5.4 years by just tackling the delirium.
And point number 5 is relating to medications that we might give patients with delirium. Now, sometimes in cases of patients with severe agitated delirium, it can be the right thing to do to give them some medications to settle them. But antipsychotics, such as haloperidol, don't come without some risks of side effects. And NICE has recommended further research into the use of pharmacological agents for the management of delirium, things like antipsychotics and benzodiazepines, because while they might decrease symptoms of delirium and improve cognition for some patients, they can interfere with cognition by causing sedation, concentration difficulties, and they can be inappropriate for some patients, such as Parkinson's patients, Lewy body dementia patients, or people with prolonged QT intervals. So those are things that we have to keep in mind. And yes, as I said, there will be times when it is appropriate and the right thing to do to settle somebody who's very agitated. In cases of people with mild or moderate delirium, it might not always be the best thing to do. And in those circumstances, it may be right to do what Georgie was chatting about and think through the PinchMe mnemonic and think, can I change their nutrition? Can I make sure they're not constipated? Have I checked that they don't have an infection? Look at the environment that they're in at the minute. It's a strange hospital ward. They feel disorientated. What other things could be causing the delirium? And try and deal with those first before resorting to medications that could be dangerous.
So this week has been all about delirium, and for some really good resources, we've put them in the show notes below. But one I really want to point you towards is some lovely infographics by Dr. Linda Dykes, who's got some lovely infographics that say delirium what to do, delirium what not to do. So they're really lovely. Next week, or this week, we're now looking at movement disorders, so things like Parkinson's, and how we manage and look after those on the wards.